Please welcome Dr. Jaime Merchant.
Good afternoon, and thank you very much for the invitation. I'm delighted to be here, and I especially like talking to a diverse group of people, especially patients, because I always learn from them. Okay, and it's when I talk to my patients about kidney cancer, it's a two-way communication. And what Deb was saying in terms of knowing that your doctor, knowing the expertise, this is critical for renal cell carcinoma because there are so many treatment options that we will talk about. So many things coming in the immediate future and so many things in the pipeline that I think it's in the patient's best interest, in your best interest, to really understand if your doctor knows about renal cell carcinoma. Okay? A little bit about my background. I did my oncology training in Boston at Beth Israel Deaconess Medical Center, and from the beginning, my interest was in tumor angiogenesis, which is a predominant feature in kidney cancer. I did my lab research with a kidney cancer researcher, and my clinical interest at Beth Israel was with Dr. Mike Atkins, who is one of the big names in kidney cancer, immunotherapy, interleukin-2, and so I really learned a lot from them. After I finished fellowship, I went actually to Mayo Clinic in Rochester because my wife, who is a doctor, had a GI fellowship, and then at that time, nobody was doing angiogenesis, and they needed a kidney cancer specialist. So I did kidney cancer there. There I brought some trials, and did a lot of kidney cancer research, some NCI-funded studies that led to some phase 3 trials later on, et cetera. And then I went to Miami because I missed the warm weather, and now I'm here. So today I will talk to you about the therapeutic options or the systemic therapy options in renal cell carcinoma. I won't talk about surgery or localized treatments because that has been discussed before. And what I would like to do is I would like to give some general information where we are now in terms of treatment, what is the immediate future, and what is coming. And that's why I said that there's a lot of hope. So I'm not going to repeat this, but the only thing that I would like to say is that renal cell carcinoma is a disease, is a malignancy that is slowly increasing in terms of incidence. And if you look at the pie chart, that is important because this has changed significantly in the last 10 or 15 years. Like when I was giving talks as a fellow a long time ago, I used to say that the local disease is diagnosed in about 30% of patients, and then regional was about 30 or 40, and the majority were metastatic. But now this has changed, especially because of the incidental findings. Many patients have abdominal pain, have an ultrasound, and find a kidney mass that is diagnosed in early stages. So even though that has improved survival, earlier detection, up to 30% of patients who have nephrectomies with the aim for cure still are at higher risk for recurrence. Renal cell carcinoma comes in different flavors, but the most common, the most popular, is the one called clear cell or conventional type, which occurs in 75 to 80% of the patients. Then papillary, which can be type 1, type 2, occurs in about 15% of the patients. And there are less common types like chromophobe, oncocytoma, and there are many other variants and subtypes that are not in this list that also can occur in patients. Many times we see mixed features, for example, papillary plus clear cell. And when patients have metastasis or recurrence, we always have to determine what tumor we're treating, because sometimes if a patient with a mixed renal cell carcinoma has a recurrence, it may be a clear cell recurrence or a papillary recurrence, and treatments may be different. So Al gave a very elegant presentation about the different pathways and the potential targets for renal cell carcinoma. And I just want to summarize what Al said, that there are probably 3 different avenues that have led to the development of new drugs in renal cell carcinoma. One, which is until recently the most popular one, is the angiogenesis pathway or angiogenesis pathways, especially VEGF, PDGF, FGF, etc. And many, many drugs have been developed and have been approved for treatment. And the way that these drugs work is by inhibiting blood vessel formation. Angiogenesis or blood vessel formation is a predominant feature in kidney cancer. Kidney cancers depend on angiogenesis. And it has been proven with trials that led to approval of these drugs that inhibiting angiogenesis is a clinically feasible and also beneficial strategy in the treatment of renal cell carcinoma. Another avenue is the Mtor pathway, which is an important pathway that is responsible for cell proliferation and cell survival. And there are 2 drugs that are available, an IV called Temsirolimus and an oral drug called Everolimus. And more recently, there have been an explosion of studies and new findings in regards to altering or modulating the immune microenvironment in renal cell carcinoma. And Nivolumab is the first drug that was approved for renal cell carcinoma. So this is a summary of the current first-line options. And I can just tell you that this is probably going to change very, very soon, okay? There will be actually more options for patients who have never been treated and are diagnosed with metastatic renal cell carcinoma. But I remember that I was involved in the pivotal trial of sunitinib that led to the approval of this drug in renal cell carcinoma that was, actually it was approved in 2006. And that was the big thing, because we had an oral agent that was somewhat effective in renal cancer. And after that, there was an explosion of many other trials, like pazopanib was approved in 2012. Temsirolimus was approved in patients with a poor risk renal cell carcinoma. Poor risk is a term or that the medical oncologists use for patients who meet several features or several clinical factors. For example, the performance status or the functional status of a patient, whether patients have anemia or not, the level of calcium, LDH, and how much time passed since the surgery until the need for treatment. And these 5 factors that were developed by Bob Motzer from Sloan Kettering could very importantly could differentiate 3 different categories of patients in terms of survival, like good risk, okay, patients who had none of those clinical factors had the longest survival, okay? And I'm not gonna give a number because this is always changing, okay? In the era of interferon and interleukin-2, the survival was about 14 to 18 months at a time. Now we count it in years. Then patients who were in the middle intermediate risk, they had a survival of about 12 to 14 months. And the poor risk patients who were sick, have high calcium, anemia, several other factors, had a very poor survival of about 3 to 4 months. But that was about 10 years ago. And this has significantly changed now. So until last year, until about November or December of last year, we had 4 first-line options, okay? Sunitinib, pazopanib, temsirolimus, and bevacizumab. And in 2017, at the end of 2017, cabozantinib was approved for first-line treatment in patients with advanced renal cell cancer, in patients who have intermediate or poor risk. So that's why it's so important for an oncologist to know about kidney cancer, because the first thing that we do when we see a new patient with metastatic kidney cancer is determine to which category the patient fits in terms of the risk factors, okay? And that would make a difference. And also, it would be important to determine whether a patient may be better candidate for a clinical trial, which, in fact, is our standard of care at the University of Miami. Our standard of care is to put patients in clinical trials, period. And we have trials for every indication in kidney cancer. Okay, and that's the way it should be. So just looking back, this is not an academic or a very detailed medical discussion, but I would just like you to look at this term. PFS is called progression-free survival, which is the time from when the patient starts treatment until patients don't respond anymore, okay? This is called median progression-free survival. And you can see that sunitinib or pazopanib and these agents, the time from treatment until the drug doesn't work anymore, in general, it's about 1 year, 9 months, 11 months, 9 months, 8 months, etc. Okay? What does that mean? That means that in many patients, even though the tumors respond at the beginning and may respond very nicely, the responses are not permanent. They don't last forever. There's a finite time in which many of these, I would call first generation agents lasted. And this is because of the development of what we call resistance to, in this case, anti-angiogenic agents. And there are two types of resistance. The most common type that we see in the clinic is patients have their tumors. We treat with, let's say, sunitinib or pazopanib. Patients have a nice response. The tumor shrinks for a while, but then the tumor grows again. The other type of resistance that we see in the clinic, less common, but we see quite often, is when patients start on the treatment and they never respond. Tumor continues to progress in spite of the treatment. Okay? We don't know how to predict which tumors will be more sensitive or which tumors will be more resistant. Okay? And this is a problem that we had when Sutent or Votrient were the only options, okay? And that there was a lot of research going on trying to overcome the resistance. So one of the goals of my research is to try to overcome resistance to these anti-angiogenic agents or even immune agents. So, and research towards understanding why tumors become resistant and what can we do is what led to the second-line options in kidney cancer. And I will give you a tour, a historic tour of when or how and why these drugs were approved. The first drug that was approved, and this is now historic, because we still use Everolimus mostly in combination, but not as a single agent, or at least not commonly. But this Everolimus was approved in 2009, and it is interesting because this drug was approved based on a placebo-controlled trial, which one would never imagine happening right now when there are so many options. But it was approved based on the positive results compared to placebo in patients who had failed drugs like Sutent or sorafenib at that time. Then in 2012, another drug was approved, axitinib, which is a new generation anti-angiogenic agent. It's like a new generation Sutent, which is a little more specific against VEGF and a little more potent. And this was approved in 2012 based on this study that compared axitinib with sorafenib. The next drug that was approved, and that made a big difference in terms of patient care and treatment, was Nivolumab Immunotherapy. And Al Copland explained you very nicely how Nivolumab and drugs like Nivolumab work. But what I explained to my patients in terms of how these checkpoint inhibitors work is that basically the tumors, when they interact with the immune system, they put a brake to the immune system. And what Nivolumab does is that Nivolumab releases the brakes to the immune system. Okay? Now, it is important to understand that as Nivolumab releases the brakes to the immune system, sometimes the immune system does not only attack the cancer cells, but attack the normal cells. And patients can have infrequent but occasionally serious immune side effects. So in this trial, Nivolumab was compared to Everolimus. And you can see here that the response rate differences were very significant. 25% of patients had tumor shrinkage, at least 30% or more, versus 5%. And basically, this is the important one, where the nivolumab was associated with significantly improved survival, 25 months, that's 2 years. Who could say that after patients failing sunitinib or pazopanib or Votrient or Sutent, a doctor would say the median survival is 2 years. At that time, before nivolumab or before these studies, doctors may say you may have 3 to 4 or 6 months. Okay? By the way, I never tell my patients how much time they have to live because I will always be wrong. Okay? So next in line came cabozantinib, which is what we call a multi-targeted tyrosine kinase inhibitor, which means that it blocks several pathways. And one pathway that is important in this resistance mechanism is MET. So cabozantinib is a MET inhibitor and also an AXL inhibitor, another important resistant pathway. And this trial, which we participated in Miami, basically compared cabozantinib versus everolimus in patients with kidney cancer who have failed Sutent or Votrient. And this is the result, okay? So it was approved in 2016 based on positive results. Cabozantinib was associated with a significant prolongation in this progression-free survival, time from treatment until patient progressed, and also a significant prolongation in overall survival of 21 versus 16 months. Finally, one of the last drug combinations to be approved in the second-line setting was this combination of lenvatinib and everolimus. It was actually done via a randomized phase 2 study of about 150 patients. And this is a combination of everolimus, which is approved as a single agent in kidney cancer, and lenvatinib, which is a new generation anti-angiogenic agent, which inhibits also mostly 2 pathways. One is VEGF, and the other one is FGF receptor. FGF is another important factor in the development of resistance. And this trial, or this drug, this combination was approved based on the results that you see in yellow here, where the median progression-free survival, and those are patients who have not responded, who have failed Sutent or Votrient, was 14.6 months, which is impressive. However, we need to take with a grain of salt because this is a phase 2 study, not a phase 3. However, I think it was enough to convince FDA to approve this agent. Objective response rate was about 43%, which is also very, very interesting compared to each agent alone. And overall survival was about 25 months as well. Okay? Now, each drug, each combination has pros and cons, benefits and side effects, as well as toxicities. And that's, again, another reason why your doctor, the kidney cancer doctor, should really be very familiar with the combinations, with the drugs, and also with many times with the literature as to, so they can inform you better. Now, I'm going to go very fast on this so we all can live on time. But so what I talked to you was the present. This is what we have right now, okay? And again, the disclaimer that I made is for the first-line options. It will probably will change very, very, very soon. And that is also very exciting. So there are several challenges that we have in kidney cancer that are the subject of intense research right now. One of these is there a role of these targeted agents pre-surgery? Okay, we know, and it is very common to see that even if patients have metastatic kidney cancer, or patients who, metastatic kidney cancer, they undergo surgery first, okay? And I will talk a little bit more about that. The question that they had asked here is patients who have localized kidney cancer and a big tumor, for example, would they benefit from these agents? Would the tumor shrink enough so they can be operable? And there have not been big studies, at least with anti-angiogenic agents. But what the study suggests, just in a nutshell, is that giving anti-angiogenic agents upfront before surgery, if we are treating clear cell kidney cancer, clear cell, it will not be detrimental. In terms of whether it's beneficial or not, many of the studies with like Sutent or axitinib, basically have shown that the tumors may decrease a little bit, but not that much, about 20% more or less. So whether this is good enough or not, the judge is out there. In my practice, when I discuss my cases with urology, I usually say, if it is doable, technically feasible, and safe, let's just remove the kidney tumor, because a 20% chance of decrease, to me, is not good enough to justify giving pre-op treatment just to shrink the tumor. Second is what do we do after surgery? Okay, many of us still believe that after surgery, the standard of care is observation. However, there is one study, the one in the middle, ESTRAC, that was published and presented, where patients who had a nephrectomy for high-risk tumors, depending on the size, involvement of the veins, or extra kidney involvement, were randomized to either Sutent for 1 year or placebo. And what this study basically showed is that 1 year of Sutent prolonged the time before the tumor recurred by 1 year. So a lot of kidney cancer experts are taking this with a grain of salt, and I'm one of those. Benefits versus 1 year of side effects. There were 2 other trials. The ASSURE trial, where University of Miami participated, was the biggest trial. It was negative. And another trial, the PROTECT trial, using pazopanib or Votrient, also was negative. So, yeah.
I know there are at least 2 of us who are intensely interested in this, but that no, immature, when you get out to 5 and 6 years and you look at the number of patients who are at risk, those are very small numbers. Is that worth talking about?
Well, like if you want, we can talk more about that. Basically, I'm not sure what was the justification for Sutent to be approved in the adjuvant setting. And it has pros and cons. The pros could be a patient, if there's no clinical trials, a patient with very high risk, like a PT3 that is involved in the veins, had lymph node that you know is going to, you as an oncologist, you may tell the patient that this is an option. But when I discuss this with my patients, I tell them, I don't know if this is going to lead to better survival. Okay, 1 year of treatment will give you an extra year without recurrence, but patients still recur. So it is and that is something that, again, is the potential issues with this is that this is not helping in accruing to the immunotherapy adjuvant trials, which are probably very, very important right now. And again, the immunotherapy trials have also some pros and some cons. But I agree that I think the majority of people who do a lot of kidney cancer are a little hesitant to put this as a standard of care. NCCN does not consider this a strong recommendation. Okay. These are some of the adjuvant trials. Like Debbie talked about the PROSPER trial, which is a great study of perioperative nivolumab versus a follow-up. Then there are different companies that are doing different of their immunotherapy agents that basically are comparing with placebo, and whether placebo, like an IV placebo versus no treatment or observation, is the best way to go. That's subject to a lot of debate, but I really am in the side of the patients in that regard. Now, the other question is whether, like, now that we have so many agents, patients who have metastatic kidney cancer, do they still need a nephrectomy before starting systemic therapy? Okay, and the answer is, in my opinion, still yes. Okay, because more and more that we have seen patients who are unresectable and metastatic kidney cancer, the primary tumor sometimes is more difficult to treat than the metastasis. And there are several trials in the past showing that doing a nephrectomy, for example, before interferon, many, many years ago, was better than interferon alone in metastatic disease. And there are several retrospective reviews that show that patients who have nephrectomy, this is a survival curve, okay, blue, survive longer than patients who did not have nephrectomy. And this is a very interesting review as well, showing the same results. Nephrectomy basically improves survival compared to non-nephrectomy in patients with metastatic disease who were going to get targeted therapy. With the difference here, the extra thing that we learn here is that not everybody benefits from nephrectomy. Okay, usually patients who are in better health, who have better organ function, and who are considered good or intermediate risk based on those criteria are the ones who benefit better, okay? That doesn't mean that patients in the poor risk group may not benefit, but that has to be discussed in a multidisciplinary manner. There's a study mostly in Europe asking that question, but I think this is probably now a little bit old now with the immunotherapy agents, but this study is trying to compare nephrectomy before sunitinib or sunitinib alone in patients with metastatic disease. So this is a big gap that we have. Treatment options for non-clear cell RCC, okay? There are trials going on that are focusing a lot in papillary with MET inhibitors, different MET inhibitors, et cetera, but still this is too little, in my opinion. What the evidence that we have is from this trial and another trial that showed somewhat similar results that compared, which were the standard at the time, either sunitinib or everolimus in non-clear cell patients. And in general, they found that sunitinib had a little better activity compared to everolimus. In patients with chromophobe renal cell carcinoma, there was an interesting inverse effect where probably everolimus may be a little more active than sunitinib. But again, this is a phase 2 trial. We always have to take with a grain of salt. And you need to discuss with your doctors as to what drug would be better for you. Now, this is more or less a slide with the current combinations that are either mature or have finished accruing, and we have some results. You see that all the studies have as a control arm sunitinib, and those are patients for studies for first line, mostly clear cell or clear cell component, who have never been treated, okay? And the green stars mean studies that have finished, phase 3 studies that have finished and have results. And the green stars are basically that they are positive, meaning that the combination, for example, of bevacizumab and atezolizumab compared to sunitinib it resulted in better outcomes. Similar, nivolumab and ipilimumab, the doublet immunotherapy combination, showed that in patients with intermediate to high risk were associated with better prognosis. One of the studies, the ASG003, which is a dendritic cell vaccine, was a negative study. So this is the in-motion study, which is atezolizumab and bevacizumab. As you can see, patients were randomized to the immunotherapy plus bevacizumab, which is an antibody against VEGF, compared to sunitinib. Just to make the long story short, this is the results. So patients had an increased response rate of about 43% versus 35% with 9% complete response rates, okay? And this was associated with improved progression-free survival, okay? This drug, this combination, I think is being considered by the FDA. It has not been approved yet, so it's still considered experimental. The other novel findings is with this study, comparing the doublet nivolumab and ipilimumab compared to sunitinib. And this was basically in patients with both good, intermediate, or poor risk, but the main endpoint or the objective of the study was to see if there was a difference of immunotherapy versus Sutent in intermediate or poor risk. And the results of the study were also similar. In this intermediate to poor risk patient population, the response rates were about 42% with immunotherapy versus 27% with sunitinib, and a 9% complete response rate. In terms of overall survival, the data is not mature yet, but in sunitinib, it was 26 months versus not reached yet for the immunotherapy combination. Again, this is for patients with intermediate or poor risk. This is actually preliminary results of a study that was presented in one of the oncology meetings, comparing another combination, axitinib and avelumab, another checkpoint inhibitor. And again, this was a small study, and they're doing a phase 3 study now that they are accruing. And that basically showed that out of 32 patients, response rate was about 58%. Again, this is patients who have never been treated. Now, this is a kind of like a table with some of the new agents, mostly immunotherapy, that are being evaluated right now in renal cell carcinoma. So it will take a long time to read and explain all of this, but there's an explosion of clinical studies that are evaluating or testing single agents or combinations with this. Most of these studies are earlier phase studies, like phase 1 or phase 2. A drug that, that was talked about a little while ago, a very, very interesting novel agent is a new drug that blocks a very, very central pathway I call HIF2, or hypoxia-inducible factor 2 alpha, kind of like one of the central directors, okay? Because HIF2 alpha, which is accumulated in kidney cancer, especially clear cell, directs the activation of hundreds of genes in kidney cancer that are associated with blood vessel formation, metastasis, metabolism, etc. So in theory, blocking this HIF2 alpha will turn the switch of many of the other pathways. And there are several drugs made by this, that block this pathway. And so there are several agents. This is, This is something that was presented in ASCO and basically shows some duration of activity of one of the HIF2 blockers. There are new HIF2 blockers coming and being tested, both alone or in combination. And so this is something very, very exciting. There are many other agents in development that are not only immunotherapy, okay? Like, for example, HIF2 blockers, as I said, agents targeting tumor metabolism. Tumor metabolism is extremely important in kidney cancer because of the nature of the gene expression profiling. These tumors tend to need more glucose, right? And some of the agents that are being tested are testing inhibitors of metabolism, or either protein or other metabolic pathways, and at least in early preclinical studies have shown promise. Other immunotherapy agents that are actually moving along in the development are OX40 agonists, IDO inhibitors, adenosine pathway inhibitors, and also, instead of doublets, triplets. Okay, for example, cabozantinib, nivolumab, plus minus ipilimumab. There's a big trial going on right now, a phase 3 trial. Okay, and one of the things that is dear and near my heart is the last option that we talked to here. It is experimental in early phase studies, but oncolytic viruses. I don't know if any of you have heard about oncolytic viruses. 90 minutes. So these oncolytic viruses are new agents, new biological agents that have potential advantages over regular treatments, because those are agents that tend to selectively infect tumor cells, replicate in tumor cells, and destroy tumor cells. And in addition to that, they may indirectly modulate the immune system or activate the immune system. So there's one trial that we are going to open at UM, with an oncolytic virus, with a vaccinia virus, in combination with immunotherapy. And there are other immunotherapy trials and other oncolytic virus trials that we have at UM. And other institutions, some of the Mayo sites also are doing some of the oncolytic virus trials that is for all solid tumors, but kidney cancer patients can also participate. So in conclusion, we have seen an explosion of new drugs, new studies, interesting results in the field of kidney cancer in the last 5 years. And the targeted agents, the ones that are approved right now, have made a big difference in the survival of patients with renal cell carcinoma. Now, immunotherapy agents and immunotherapy combinations are potentially providing even better results than anti-angiogenic agents alone. And the current research is aimed first, in terms of what we have right now, the 5 or 6 options, the current research is aimed as to determine which option is the best for the patient. And that, as I mentioned before, is a very big challenge in kidney cancer. How can we individualize? But there are several hints that oncologists who do kidney cancer have as to how indirectly individualize the treatment options, depending on symptoms, depending on where the metastases are, depending on how fast the tumor is growing or not. Then oncologists can choose one or the other options. But bottom line, like, we have all these treatments because of clinical trials and because of patients like you who volunteer to participate in the trials, thinking in your best interest, but also thinking on helping other patients. And other needs that we have, that I actually, every time that I am presented with a kidney cancer trial, okay, the first question I ask is, can we do it for patients with non-clear cell? Okay, and many times the answer is no, many times the answer is maybe, and I may be able to convince them. But this is an unmet need, non-clear cell RCCs. Okay, I see young patients with non-clear cell RCCs that have no options, and it's very, very sad. Okay, and usually the regular FDA-approved treatments for clear cell don't work as well in non-clear cell. Patients with metastatic renal cancer still progress, and even though the drugs work for a while, tumors become resistant. So there's this unending fight that both doctors and patients go together to try to find new treatments and hopefully to try to find a cure for kidney cancer. The new therapies, the new strategies like HIF-2 blockade, oncolytic viruses, novel immunotherapy combinations are actually will bring new hope. Okay, hope for the cure, I don't know, but hope for probably for a better tomorrow. In terms of now that we have advanced so much, there's a big chance that we will further advance to help our patients. And I think that's it. I will finish here, and thank you very much. Yes, sure.
I've got a couple of questions. First question is, you mentioned the increased incidence of kidney cancer. What is the cause of the increased incidence?
Well, nobody really knows what the cause is. There are several risk factors, okay? One of the most common risk factors is smoking, which is an established risk factor. There are other risk factors that have been now put more in consideration, like overweight and obesity. That is now an established risk factor for renal cell carcinoma. And we see patients who are overweight or obese who come with newly diagnosed kidney cancer. Chemical exposure is another risk factor. But I think one of the reasons why the incidence is increasing may be because it is being discovered more often now. Before, a patient with kidney cancer was discovered when he was very advanced and metastatic, okay? And now patients are discovered when they are at earlier stages. So if you move the timeline a little bit to the left, a little bit earlier, you will see that the numbers are higher. but the numbers are higher because the stage of diagnosis is lower as well. Now, like as I said at the beginning, 15 years ago, about just 30% of the patients had localized disease at diagnosis. Now about 60%, double number of patients have a diagnosis at the early stage. So that may be one of the reasons why there's this increase in the numbers. But, yeah.
May I ask my other question? And it has to do with the oncolytic viruses. How would a trial with oncolytic virus be set up? I mean, what kind of control do you have?
There's no control. Those are early phase trials. They're basically, remember, phase 1, phase 2, phase 3. Some of these trials that are using oncolytic viruses are very, very new, and they're phase 1. So there's no control. Everybody gets either the virus and or a virus plus another agent, depending on what trial it is, but everybody gets the agent. And the main objectives are safety, tolerability, and early evidence of efficacy. We always look for that. We do the scans and everything.
Are those patients admitted to the hospital?
Well, it depends on the trial. In some trials, some trials involve injection into one of the tumors, one of the metastases, and they may be observed for the day and they go home. Some other trials require overnight observation, like 23 hours or something. Yeah.
Okay.
Okay.